Hi, my name is Dylan, and today we're here to present on calcium oxalate kidney stones. My team members are Pablo, Jenny, Tania, and myself.
And this is our case presentation. Mr. Hendrix, a 68-year-old Anglo-Australian male, has presented to the doctor's clinic complaining of severe sharp pain radiating from his left flank to the groin region. The pain comes in waves and can last for up to 1 hour each time. He also states that he has been feeling restless, nauseous, and has noticed a major increase in the frequency of passing urine, which also contains traces of what appears to be blood. He is also experiencing difficulty of passing urine. His history is that Mr. Hendrix has a BMI of 30, however he is independent, mobile, lives with his wife, and has been working as a chef for the last 40 years. His children are grown up and have moved out of home but visit on a fortnightly basis. Mr. Hendrix has a family history of kidney stones and renal tubular acidosis from his father's side. This is the pathophysiology of kidney stones. Kidney stones, also known as renal calculi, are aggregates of crystals that develop within the kidneys. They are classified according to the specific types of crystals that they contain and fall within 5 major categories. Struvite stones result from kidney infections. Uric acid stones result from urine being persistently acidic. Cystine stones result from a genetic disorder. Calcium phosphate stones result from high urine alkalinity and calcium content. And calcium oxalate. Calcium oxalate is the most common type of kidney stone and is believed to be caused by high calcium and oxalate excretion. No single theory can account for stone formation in all cases. However, there are 3 main theories in regards to kidney stone formation, which is the free particle theory, fixed particle model, and Renal's plaque hypothesis. The first step of calcium oxalate kidney stone formation is nucleation. Calcium and oxalate ions that have been filtered into the urine by the kidneys join together and form a solid crystal formation in the lumen of the nephron. Step 2 involves the tiny crystal formations traveling down the nephron and being deposited at the renal papilla, where they undergo the process of growth. In the third stage, the fully grown crystals begin to aggregate, which results in the formation of a full-sized kidney stone. New stones are retained in the kidney and are exposed to supersaturated ultrafiltrate, which facilitates their further growth. After an unspecified amount of time, the kidney stones are displaced and travel from the kidney into the ureter, potentially causing obstruction of that tubular segment, which can result in excruciating pain known as renal colic. Supersaturation of urine with strong forming salts such as calcium oxalate, phosphate, and uric acid is a critical factor in regards to the formation of renal calculi because it is the driving force behind crystallization. When urine is undersaturated, crystals cannot form. Deficiencies in inhibitors such as citrate also play an important role in stone formation, as citrate retards the nucleation, growth, and aggregation process by binding ions needed for crystal formation and growth. People who form kidney stones are known to suffer from a variety of metabolic disturbances that increase the amount of stone-forming substances being excreted in the urine, for example hypercalciuria and hyperoxaluria, and decrease the excretion of inhibitors such as citrate and low pH. Environmental stresses play a significant role in kidney stone disease. For example, high temperatures and humidity trigger excess water conservation in the kidney and may cause dehydration. A diet high in sodium is also a risk because it increases calcium excretion and reduces urinary levels of stone-inhibiting citrate. Excess animal protein also encourages stone growth by increasing urinary uric acid and reducing urinary citrate once again.
Under normal circumstances, calcium stones generally pass without any complications. However, some stones, depending on whether they cause obstruction, infection, unrelieved pain, or hematuria, require interventions. Stones that are less than or equal to 6 mm in transverse diameter will pass spontaneously. The function of the kidneys are to act as a filter and flush out the accumulated calcium along with waste products from the blood and converting it to urine, but when this doesn't happen, the calcium ions join with waste products forming a stone. Recurrence happens when patients that have a history of renal calculi. There is a 50% chance of recurrence within 5 to 10 years and 75% of recurrence within 20 years. Recurrence of renal calculi is common but can be hindered using preventative measures such as encouraging fluids, adequate dietary intake, and a change in lifestyle. Infection is caused if the stones are left untreated or because there is a kidney blockage for an extended amount of time. It can cause loss of renal tissue and function. Acute unilateral urethral obstruction is the blockage of the flow of urine out of one of the kidneys and ureters, caused when renal calculi are too big in size and do not pass spontaneously, leading to accumulation of urine in the kidneys, thus causing swelling. Renal colic is pain caused by stones that are 1 to 5 millimeters in diameter that obstruct the flow in the ureter. The pain by renal colic is caused by dilation, stretching, and spasms due to acute unilateral urethral obstruction. The sudden onset of renal colic is severe pain, usually in the flank radiating inferiorly and anteriorly. Most patients complain of nausea and vomiting with renal colic. Hematuria is the presence of red blood cells found in the urine. It generally occurs when renal calculi causes aggregation to the lining of the kidneys or ureter.
So there are a number of medications to help treat kidney stones. Pain relief for renal colic should be the first goal in terms of medication. They can range from paracetamol to morphine. Suppositories, Panadine, Endone, and Oxycodone have been used in the past. Opioids are also an option. Ibuprofen is an NSAID that has a number of uses, such as the management of acute or chronic pain. This includes renal colic pain that Mr. Hendrix may experience from kidney stones. Contradictions to ibuprofen include a history of or an active peptic ulcer, aspirin or anti-inflammatory allergies, severe heart failure or peripheral arterial disease, cerebrovascular disease, and uncontrolled hypertension. Adverse effects include GI upset or hemorrhage, rashes, and thrombocytopenia. For safety, Mr. Hendrix's allergies should be taken into account, if any, along with the patient's medical history if they have asthma or any heart problems, for example. If used concurrently, increased diligence must be employed in monitoring for bleeding, bruising, and altered mental status. Tamsulosin. This is an alpha-adrenic blocker agent. It relaxes the smooth muscles of the ureter, facilitating the movement of larger kidney stones that may not necessarily pass on their own. It is contradicted with other alpha-adrenoceptor blocker agents and those with a history of orthostatic hypotension and severe liver or renal impairment. Prostate cancer and other urological conditions should also be ruled out before therapy can commence. Adverse effects specific to the drug include an abnormal ejaculation, priapism, and dizziness. Patients should be advised to swallow the capsule whole and for it not to be chewed. There are no current routine tests that are recommended for monitoring. Indapamide. This is a thiazide diuretic. It reduces calcium excretion, decreasing the chances of another calcium stone. It is contradicted with anuria, hypersensitivity to indapamide, severe kidney or liver failure, and a low blood potassium level. Adverse effects include asthenia, fatigue, muscle cramps, and orthostatic hypertension. The medication should be discontinued if there are any electrolyte disturbances like hypokalemia, rashes, or reports of photosensitivity. Like the previous, it should not be chewed or broken, swallowed as instructed by the nurse. It is recommended to monitor the potassium and uric acid serum levels of Mr. Hendrix. Blood electrolytes may also be taken to check for a fluid or electrolyte imbalance. Allopurinol. This reduces the production of uric acid in the body. Uric acid buildup can lead to gout or kidney stones. Uric acid facilitates the precipitation of calcium oxalate crystals. Ultimately, calcium stone formation can be reduced by this medication. Contradictions include acute gout or allergies towards it. Adverse effects may include rashes, nausea, vomiting, abdominal pain, headaches, fever, drowsiness, and vertigo. Skin reactions can also occur, requiring immediate withdrawal, though it can be restarted at a lower dose once it disappears. Caution should be taken in those with liver or renal impairment, as they require a lower dose, and those with hypertension or cardiac insufficiency. Mr. Hendrix should be warned against operating vehicles or machinery if experiencing vertigo. Diabetics should also have their blood glucose levels closely monitored.
Nursing management covers initial patient care, a primary and secondary assessment, a focused assessment based on the renal system, and overall nursing care related to kidney stones. Initial care is when you introduce yourself to the patient, check if patient has any toileting needs or pain, assist with identified needs, familiarise the patient with the environment such as where the nursing buzzer is, bedside table and bed light, Maintain confidentiality and privacy at all times, and always gain consent. A primary assessment is initiated as you walk into a room. It covers the danger response, send for help, airway, breathing, circulation, disability, and exposure. Observations are also taken and documented. The patient's respiratory rate, blood pressure, OT stats, temperature and pain level, and blood sugar levels are documented. A secondary assessment covers health history and head-to-toe assessment. A health history includes subjective data such as biographical information, past health history, family history, health and lifestyle practices, psychosocial development, their sleep and eating habits. A head-to-toe assessment covers objective data, which are physical characteristics when you inspect, palpate, auscultate, and percuss. The body systems covered are the neurology, respiratory, cardiovascular, abdominal, renal, skin hygiene, mobility and risk falls, and endocrine body systems. Our focus assessment was the renal system. With this patient, they are presented with kidney stone symptoms such as severe pain, blood in the urine, nausea and vomiting, shivers, sweating, foul-smelling urine, gravel in the urine, and urgent need to urinate. To detect kidney stones, an ultrasound would be done, or a CT scan, X-ray, including intravenous pyelogram, which is an IVP for short, which is an injection of dye into the bloodstream. To treat kidneys, an extracorporeal shock wave lithotripsy ultrasound is performed, which are waves used to break up the kidney stones. Also, a percutaneous nephrolectomy is a small incision made in the back of using a small special instrument. There is also a choice of an endoscope removal, which is an instrument inserted into the urethra and passes into the bladder, and finally surgery. So finally, the overall nursing care would be to reduce the patient anxiety, promote patient comfort, reduce patient pain level, monitor fluid and electrolyte balance, document using a fluid balance chart, perform a urinalysis test for infection, full bloods to check the lab test to identify any kidney function and medications. Thanks.
And these are the following techniques or nursing management that we will use for the specific symptoms. For acute pain management, to specifically determine the pain characteristics, the nurse will note the location, duration, intensity, a 0 out of 10 scale, and radiation of the pain. Non-verbal signs such as elevated blood pressure, pulse, restlessness, moaning, and thrashing about will also be documented. The rationale behind this is to evaluate site of obstruction and progress of the kidney stone movement. Flank pain suggests that the stones are in the kidney area or upper ureter. Flank pain may radiate to the back, abdomen, groin, and genitalia because of proximity of the nerve plexus and blood vessels supplying these areas. Secondly, the cause of the pain must be clarified to the patient, stressing the need of notifying caregivers of changes in pain occurrence and characteristics. This will provide the opportunity for timely administration of analgesia, which is helpful in enhancing patient coping ability and may reduce anxiety. Timely notification will also alert the nurse to the possibility of the stone passing or other developing complications which the nurse must address. The nurse will also implement comfort measures such as a back rub or warm compress to the back. This will promote relaxation, reduce muscle tension and reflex spasms, and enhance the patient's coping ability. The nurse will encourage use of focused breathing, guided imagery, and diversional activities. This will redirect Mr. Hendrix's attention and further aid in muscle relaxation. The nurse will also encourage and assist with frequent ambulation. This is important because renal colic can be made worse in the supine position, so it's important for Mr. Hendrix to move about. The nurse must also document reports of increased and persistent abdominal pain, because this may be a sign of complete obstruction of the ureter, which can cause perforation and leakage of urine into the perirenal space, which requires an acute surgical emergency in this case. Also, medications will be administered as charted, and as Dylan discussed previously, and all the contraindications and symptoms and risks will be observed on Mr. Hendrix. For urinary elimination management, the nurse will record an intake and output of fluids through the fluid balance chart, as Tania just mentioned previously. and the characteristics of urine culture and sensitivities. This action provides information about kidney function and potential presence of complications such as infection and hemorrhage. For instance, bleeding may indicate an increase in obstruction or irritation of the ureter, or the presence of certain cultures within the urine specimen may indicate a UTI. The patient's normal voiding pattern and variations will also have to be determined. Calculi may cause nerve excitability, which causes sensations of urgent need to void. Usually frequency and urgency increase as calculus nears the uretrovesical junction. The patient will also be encouraged to walk if possible, also promoting sufficient intake of fluids, and the nurse will also offer fruit juices, especially cranberry juice. This is because increased hydration helps to flush bacteria, blood and debris, and being active by walking may facilitate stone passage, while the juices help to acidify the urine. The urine will be strained, and documenting any stones that come out and be sent off to the laboratory. Retrieval of kidney stones allows identification of the type of stone and influences the choice of therapy for future scenarios. The nurse will investigate reports of bladder fullness, palpating for suprapubic distension, and noting any further decreases in urine output and presence of periorbital and dependent edema. This will help to observe for urinary retention and bladder or kidney tissue distension, which can potentiate risk of infection and ultimately renal failure. The nurse may use an indwelling catheter if required and maintain their patency, ensure there is no obstruction within the catheter. This will help to facilitate urine flow and also prevent urinary stasis and retention, reducing the risk of increased renal pressure and infection. The nurse must also observe for changes in mental status, behavior, or level of consciousness. Striking cognitive alterations and impairments may be a sign of accumulation of uremic wastes and electrolyte imbalances, which can be toxic to the central nervous system. Monitoring for the risk of fluid deficiency will also be important. Again, intake and output of fluids will again be monitored and documented in conjunction with daily weighing. The rationale behind this is that comparing actual and anticipated output may aid in evaluating presence and degree of renal stasis or impairment. Rapid weight gain may be related to too much water retention, which will have to be addressed. The nurse must also document characteristics and frequency of vomiting and diarrhea, if present, as well as accompanying or precipitating events. This is because nausea, vomiting, and diarrhea are commonly associated with renal colic, and documentation may help rule out other abdominal occurrences as a cause for pain, and also help to pinpoint kidney stone location. Fluid intake of 3 to 4 litres a day will also be promoted, as this will maintain fluid balance for homeostasis and may flush the stones out, and also helping to prevent dehydration and electrolyte imbalance, which may occur secondary to excessive fluid loss. The nurse will monitor vital signs, evaluate pulses, capillary refill, skin turgor, and mucous membranes, as these are all indicators of hydration and circulating volume of fluid, where deficiency will signify a need for intervention. Checking hemoglobin, hematocrit, and electrolytes, as Tania mentioned before, through blood tests may also be helpful, as these diagnostics assess the effectiveness of hydration within the body. If a patient can't drink the required amount of fluids, supplemental IVs may be given. This will help to maintain circulating volume again and promote renal function. As this is Mr. Hendrix's first experience with having kidney stones, he most likely has deficient knowledge in regards to this condition, prognosis, treatment, self-care, and discharge needs. For the nursing interventions, the nurse must help to increase the patient's understanding of the disease process, potential complications, and future expectations, as this will provide a basic knowledge base from which the patient can make informed choices. The nurse must also make a strong emphasis on increased fluid intake of 3 to 4 litres a day, or as much as 6 to 8 litres a day in Mr. Hendrix's case, because he's a chef that works in a hot, humid environment, which increases the risk of dehydration. Mr. Hendrix must understand the importance of fluid needing to flush the renal system in order to decrease opportunity for urinary stasis and stone reformation. The nurse will also help the patient review his dietary regimen. This will help Mr. Hendrix in understanding reasons for various dietary restrictions in regards to products high in calcium and oxalate levels, and provides opportunity to make informed choices, increases cooperation with the regimen, and may prevent recurrence of the stones. The nurse will also discuss the medication regimen and stress the importance of reading all products or food ingredient labels. This will help the patient be aware of ingesting products containing individually contraindicated ingredients which can potentiate recurrence of the stones. Promotion of regular activity and exercise is also important, as this will help the patient because inactivity contributes to stone formation through calcium shifts and urinary stasis. The nurse must also use active listening therapy in regards to the patient's concerns about the regimen and lifestyle changes. Also, promotion of family and social support is very important. This will help the patient work through feelings and gain a sense of control over what is happening and feel supported in his therapy, making lifestyle changes easier and the treatment more effective. The patient must also learn to identify early signs and symptoms requiring medical evaluation, such as the pain, hematuria, and oliguria. This is important because after his first episode, he is about 50% or 75% more likely, as Jenny mentioned before, that he will experience a recurring episode of kidney stones. And this will require prompt interventions in order to prevent serious complications.
National Safety and Quality Health Service Standards. So 3 we picked were partnering with consumers, medication safety, and patient identification and procedure matching. Partnering with consumers allows the doctor's clinic to meet the needs of Mr. Hendrix through partnerships and to encourage Mr. Hendrix to actively participate in his own experience and health outcomes, also allowing him to receive information on the health service he is admitted to and evaluate the care he has been given for quality improvement. With medication safety, the doctor's clinic should check the 7 right before dispensing medication to the patient to ensure the right medication is going to the right patient for the right reasons, also informing the patient about the options, risks, and responsibilities with adhering to the agreed medication plan. Patient identification and procedure matching relates to confirming Mr. Hendrix's identity whilst at the doctor's clinic, using at least 3 approved identifiers such as his full name, date of birth, and address, usually found on a patient's identification band.
And that concludes our presentation. Here is the reference list for each group member, and this is the appendix for the images. Thank you for your time.